The Bellini Trial. 47% complete response in TNBC using dual inhibitors alone. Less toxicity, big potential. ASCENT-04. Sacituzumab govitecan plus pembrolizumab boosts PFS to 11.2 months. 35% risk reduction, new standard? These 2025 breast cancer updates, and much more coming up now.
Tell us about winning the MOASC Young Investigators Award.
I won the MOASC Young Investigator Award with a project looking at the gut microbiome from samples in a phase 2 trial, which investigated adding pembrolizumab to HER2-targeted therapy in the neoadjuvant setting for early HER2-positive breast cancer. And so we're currently doing the project right now with that funds and have found some really interesting results. We have submitted that project as an abstract to San Antonio Breast Cancer Symposium, awaiting the results of that. So I think it really has the award has given me the opportunity and the funding to do a really exciting project with immunotherapy in the breast cancer space.
How does pembrolizumab in KEYNOTE-522 help early-stage triple-negative breast cancer patients live longer? And what's unclear about chemo mixes?
Currently, pembrolizumab is approved in early triple-negative breast cancer based on KEYNOTE-522, and that showed improved pathologic complete response rates compared to patients who received just chemotherapy. And then subsequent analyses from the trial have shown improved recurrence rates as well as improved overall survival. So adding immunotherapy does improve outcomes in patients with early triple-negative breast cancer. However, KEYNOTE-522 was a very intense chemotherapy and immunotherapy regimen. So trials are investigating right now how we can de-escalate therapy both in the neoadjuvant and the adjuvant space.
How many in the NeoPAC trial had a complete response without anthracyclines? And how does that link to Scarlet?
So the NeoPAC trial was a phase 2 study which looked at combining chemotherapy with immunotherapy. However, it used 2 different chemotherapies, carboplatin and docetaxel with pembrolizumab for 6 cycles. And this resulted in a pathologic complete response rate of 58%. And this was specifically an anthracycline-free regimen as compared to KEYNOTE-522. So hopefully sparing patients from the toxicities related to anthracyclines, which can lead to cardiac and more severe toxicities related to future cancers.
Why might some need extra chemo in NeoStar with sacituzumab govitecan and pembrolizumab, and could it reduce side effects?
So the NeoStar trial was a phase 2 study which looked at combining sacituzumab govitecan plus pembrolizumab for 4 cycles. In patients who were thought to have a pathologic complete response, they went straight to surgery. For patients who were thought to have residual disease, they underwent additional chemotherapy. And in patients who were thought to have a PCR, they had a PCR, or who went straight to surgery, they had a PCR rate of 33%. Some patients who were not thought to have a PCR underwent additional chemotherapy and had an even better response rate with the additional chemotherapy. And this was using an anthracycline-free regimen. And so we're hoping that potentially combining an ADC, the sacituzumab govitecan, with an immunotherapy, and then using a chemotherapy regimen that doesn't include an anthracycline may allow for patients to receive a less toxic regimen than KEYNOTE-522.
How well did Bellini's 2 immune-boosting drugs without chemo work for high immune cell tumors? And could it help more later?
So the phase 2 Bellini study looked at combining these 2 dual immune checkpoint inhibitors in patients with triple-negative breast cancer with high tumor-infiltrating lymphocytes, specifically TILs greater or equal to 50%. And when these patients were given Ipi-Nivo, this resulted in a pathologic complete response rate of 33%. And in patients who were given Ipi plus relatlimab, they had a PCR rate of 47%. So this is pretty encouraging results. The PCR rates were not as good as compared to KEYNOTE-522, but that was a very toxic regimen with 4 different chemotherapies. And so this suggests that potentially we may be able to identify a cohort of patients who can be spared chemotherapy, only receive immunotherapy, but more studies are needed to figure out which patients may benefit from that.